Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Nadia Harbeck. I'm the director of the Breast Center at the LMU University Hospital in Munich, Germany. Welcome to this activity, Lessons from the Real World, Treating High-Risk Hormone Receptor Positive HER2-Negative Breast Cancer According to the Latest Evidence. Joining me today are Dr. Stephen Johnson. He's a professor of breast cancer medicine and consultant medical oncologist at the Royal Marsden NSA Foundation in London, and Dr. Sarah Tulane. She's an associate professor of medicine at the Harvard Medical School and chief of the Division of Breast Oncology at the Dana-Farber Cancer Center in Boston, Massachusetts. Welcome to you both.
Hi there.
Thank you. It's going to be a pleasure doing this together with you. The landmark Monarchy and Natalie trials have transitioned CDK4/6 inhibitors from the metastatic setting to adjuvant standard of care. This now allows us to significantly reduce invasive recurrence risk for our patients at high risk through more nuanced, targeted escalation in therapy. Let's take a closer look. Let's start with the study that reported out first. So, Stephen, could you take us through the most recent updates of the Monarchy study, please?
Yes, sure. So I think we're all aware that the Monarch E trial is a randomized phase 3 trial in high risk early breast cancer, hormone receptor positive. And the patients that were selected for this trial were deemed to be at risk of recurrence based on nodal burden. So 4 or more nodes, or of 1 to 3 nodes, an additional risk factor of either grade 3 or large tumor size. And it's been shown before that this identified a patient population with a significant increased risk of recurrence despite standard of care. A second smaller cohort 2 was added if there was smaller anatomical risk, so 1 to 3 nodes, maybe a grade 2 tumor, smaller size, but a high proliferation Ki67. The trial recruited 5,500 patients, randomized in an open label fashion after primary surgery and radiotherapy and chemotherapy to either endocrine therapy alone or adjuvant abemaciclib, 2 years of treatment plus the endocrine therapy. And patients were followed up and endocrine treatment continued up to 10 years. The trial is positive and led to the approval of abemaciclib based on the primary endpoint of invasive disease-free survival. So the latest data cut from last July, when the median follow-up of the trial is now 6.3 years or 76 months, provided more mature data on the trial and allowed us also to look at what the more mature 7-year estimate of improvement in invasive disease-free survival would be. And if we look at that data first in terms of the updated analysis on invasive disease-free survival, we know that there is at least a 26% reduction in risk of recurrence, and the absolute difference is now about 6.5% at 7 years. The curves separate after the first initial year and continue to separate between years 2 and 5. And then between years 5 and year 7, the curves stay apart. So it's a very mature data set with a substantial reduction in risk. But these are high risk patients, such that at 5 years, 1 in 4 of them will have relapsed, and you can reduce that by 25%, absolute difference of about 6 to 7%. So it's a really meaningful benefit. And most of the recurrences that are prevented are metastatic disease. And we can see that distant recurrences were reduced from 523 down to 381. And that local recurrences were also reduced, and that's part of the IDFS endpoint. And most of the recurrent reduction occurred in both bone and liver metastases. So the survival analysis now shows that there is a significant reduction in the number of deaths. So 360 in the endocrine therapy alone arm, 301 in the combination arm. And that results in a significant reduction by about 15.8% relative reduction in risk of death. The absolute difference at 7 years is estimated to be 1.8%. And again, the difference emerges at 5 years and starts to separate out between 5, 6, and 7 years. This was statistically significant, and this, therefore, was the very first time that overall survival has been improved in an adjuvant study of CDK inhibitors. When you look at the causes of deaths, they are either related to breast cancer or to other events. And the events that drive distant disease free survival, which is another of the secondary endpoints, are development of metastatic disease or death for any cause. But when you look in the histograms, you can see that the reduction in metastatic disease is very significant. 30% fewer patients either alive or who've died from metastatic breast cancer. And as we continue to follow the trial, we anticipate that if metastatic disease is what's driving overall survival, these differences will continue to emerge. Benefit was seen across all the pre-specified subgroups without any statistical interaction. So there's no one group that derived more or less benefit. There is benefit across the board. But one of the questions that's been raised is whether or not tumors that are higher proliferating tumors are the more aggressive ones and they get all the benefit, whereas the slower, lower proliferating tumors get no benefit. So within the trial, we did an analysis based on Ki67, and the cutoff of 20% was the international standard that was chosen at the time to say either high or low Ki67. And we've displayed data for the primary endpoint, IDFS, the secondary endpoints of distant relapse-free survival, and overall survival, and show that the benefit is seen regardless of whether you have a high Ki67 or a low Ki67. The issue with the high Ki67 is that the events are occurring much more quickly. So again, here the hazard ratio for overall survival in the high Ki67 is even stronger at 0.717. It's just that the lower Ki67, the events occur more slowly, but there is still the same magnitude of benefit that is seen in terms of risk reduction. The late adverse events were also looked at in this analysis, and there was no new signal of a late adverse event. And the adverse events that resulted in death are displayed, including infections during the pandemic, because the trial was run during the pandemic. So there was a slight excess of deaths not related to breast cancer due to infections and COVID in the abemaciclib arm. But there was no difference in cancers of other sites or cardiac issues. So, Nadia, back to you to continue our discussions. But those were the latest data from the Monarch E trial.
Thank you, Stephen. There was a very nice, concise summary. Sarah, there's been also updates for the Natalie study at the same ESMO meeting last year. So, would you mind just walking us through the latest data?
Yeah, so as you point out, at that same ESMO meeting, we saw a longer follow-up from the Natalie trial. The design of Natalie was slightly different than Monarch E in that there was a broader patient population that was enrolled into Natalie. So, to be eligible for this trial, you either had to have any lymph node involvement. You didn't need an additional high risk feature if you had nodal involvement. But if you were node negative, you had to either have a tumor that was over 5 centimeters, or if between 2 to 5 centimeters, you had to have an additional high risk feature, meaning the tumor either had a high proliferation score or had a high genomic assay score or was high grade. And so this patient population was then randomized to get adjuvant endocrine therapy. In this case, it had to be an aromatase inhibitor. You cannot utilize tamoxifen concurrently with ribociclib, so they restricted it to an AI with or without ovarian suppression, or to get that AI with ribociclib. Here, the dose of ribociclib, importantly, is at 400 milligrams, 3 weeks on, 1 week off, not the traditional 600 milligram dose that is utilized in the metastatic setting. They had lowered the dose because they knew people were going to be on this for a while and wanted to try to mitigate some of the side effects that do occur with ribociclib. And they also chose to use a longer duration of therapy. So here it was for 3 years as opposed to the 2 years that abemaciclib is given in Monarch E. And the primary endpoint here was invasive disease free survival. And what we've seen now is about 5 years of follow up. So we have now really continuing to show the curves separate with a hazard ratio of 0.71, so about a 30% reduction in risk of invasive disease free survival events, with an absolute difference of 4.5%. So you do see that the curves continue to separate over time, which is really important. And you also see that the vast majority of events were, in fact, distant events. So, really important that, again, what we are preventing predominantly are the distant events. The benefit that we're seeing also was consistent across pre specified subgroups. So, you're seeing benefit in pre and postmenopausal patients, people, whether they got chemo or not, stage two, stage three patients. And similar to what Stephen had presented with regards to proliferation, you see benefit in those with low or high proliferation. What I think is a little bit unique about Natalie, though, is they did include that N0 population. So that is different, again, than the Monarch E study. And so I think one of the questions we've had is how well actually does the CDK4/6 inhibitor work within this population? And so they have presented data that is separated by N0 compared to node positive patients. And when you look at the node negative patients, you do see that the hazard ratio is similar to the overall population. So it was actually a little bit better here, is zero point 0.6. And the absolute difference was 5.7%. The thing I would, however, note is that this is a small cohort of patients. And so the confidence interval surrounding these estimates is very wide. And the number of events actually separating the two arms is only 21 events. And so while we see this very nice hazard ratio and absolute difference, I would just interpret this with a little bit of caution given the sample size and the wide confidence intervals. But clearly, you do see that there is separation of the curves, whether someone had node negative or node positive disease. And when you again look at distant events, so if you look at distant disease free survival and distant relapse free survival, again, because the vast majority of events here were distant, you are seeing this very consistent hazard ratio of around zero point 0.7. Overall survival data is still immature, but you do see a very nice trend with a hazard ratio of zero point 0.8 and the absolute difference of 1.6%. I would note that overall survival here is a secondary endpoint, but there was no alpha spending that was incorporated into the OS analysis. And so I think one just has to interpret it a little bit with caution, but nice again to see that there is starting to be some separation between the two curves for overall survival. And, importantly, when you look at the number of patients who are living with metastatic disease, it is significantly lower in the arm where patients got ribociclib. So this is similar to what we saw with abemaciclib. People do live with metastatic disease, thankfully, for many years. And so to see overall survival differences often does take time. So Nadia, I'll pass it back to you.
Thank you. I just one point I noticed when you talked about the curves for node negative and node positive. I think that maybe one of the reasons that there is an absolute bigger difference between the curves node negative is that they were selected by high risk features, whereas node positive patients, I mean, they're all comers. There are also some in there, and we'll talk about this when we talk about the case, maybe with a very good biology. Would you agree with that?
Yeah, I think you're right. They were picking out very unique node negative patients, right? These are the high recurrence score patients or the high proliferation or high grade. And so, as you point out, they definitely, their baseline risk is high. In fact, I think very similar to, node positive patients. In fact, even higher risk than some of the, low proliferation node positive patients. So, I think that's exactly right.
And I think that's really important to point out because nodal status isn't the sole factor. And Natalie had the high risk node negatives, whereas monarchy they were all high risk based on established clinical pathological features. Natalie's wider broad set has raised questions about whether everybody's got that same level of risk in the trial.
And that brings me to the summary of both trials, just looking at the differences. Duration of treatment was 2 years in monarchy, with 3 years with ribociclib. And obviously, since monarchy has a higher risk population, we do have slightly lower IDFS and lower distant recurrence-free survival than in the Natalie study. And the dosing in monarchy is the dosing we know from the metastatic setting will maybe we'll talk a little bit also about some modifications that we can do later on to sort of make it easier for patients to reach that optimal dose level. And in the NATALY, we have 400 milligrams at the regular scheduled 3 weeks on, 1 week off. I think the side effect profile we know from the metastatic setting, we have GI toxicity, mostly diarrhea in the Monarch E study, and hematological toxicity, liver toxicity, and some QT prolongation in the NATALY study, although less than in the metastatic setting given starting dose. And then there's some reports of ILD, pneumonitis. There's more with the bimacyclib than with ribociclib. But personally, I have not seen a case of ILD with my CDK4/6 inhibitor patients. So maybe that is a very rare occasion. So let's go to the case, and maybe then it gives us some chance to also discuss the pros and cons of which drug to use in which setting, and also maybe how we can counsel our patients on their residual risk before they start the CDK4/6 inhibitor. Let's take a postmenopausal woman, 61 years old. She has a T2 tumor, 2.1 centimeters, grade 3 invasive ductal carcinoma. One lymph node out of 18 was involved. The tumor is highly ER positive with a score of 8, PR3, and HER2 2 plus fish negative. And we have a proliferation index of 25%, which is sort of on the higher end of the spectrum. So, Stephen, why don't you start? So, what would you recommend to this patient?
Well, I think it's clear that there are some increased risk factors here. The nodes are positive, albeit the burden of nodal involvement is low, just one involved lymph node. The tumor's T2, but only just T2, but it's biologically a higher risk cancer, as shown with being grade 3, and that's almost certainly driven by the higher proliferation rate that we can see. But again, if we look at the biology, ER8, PR3, and HER2 2 plus, but fish negative. So this looks more like what we call a luminal B cancer, with lower progesterone receptor, higher proliferation, so a higher risk ER positive cancer contributing to the grade. So this patient would certainly have been eligible for the inclusion within the Monarch E trial based on those criteria because they would be deemed to have a risk of recurrence that is high. Now that's been demonstrated in recent real world data about the N1 patient, because if you look at the N1 patients between 1 and 3 nodes and say, yes, they've got a high risk feature, 1 or 3 nodes with grade 3 or large tumor size, versus all other patients, so N1 positive, but perhaps a grade 2 tumor or a smaller size or a low Ki67, there are big differences in their risk of recurrence. And this is real world Flatiron data that's just been published in ESMO Open this last month. And the high risk patients can have up to a 1 in 4 chance of recurrence at 5 years, but only a 1 in 10 chance of recurrence if they've got low risk features. So that risk is really substantially different by just those additional factors, even if the nodal burden was the same. And that can also impact in up to a 6% difference in overall survival. And that's not with the addition of CDK inhibitors, that's just the prognosis being treated with conventional therapy. So I think the selection of N1 with high risk definitely shows that they've potentially got up to a 1 in 4 chance of recurrence with standard of care, and therefore definitely would be indicated for CDK inhibitors, and certainly with abemaciclib within its licensed indication.
So, Sarah, if the tumor was grade 2, do you think it's a significantly lower risk of recurrence, or would you still think with the one involved lymph node, she needs a CDK4/6 inhibitor?
Yeah, that's a really good question. Here, if she were grade 2, as you point out, she still has a node involved. She still actually did have a high proliferation score. So technically, she would have fallen outside of cohort 1 eligibility for monarchy, but actually would have fit cohort 2 eligibility because she would have had the high proliferation score. The patient also would have been eligible for Natalie because really the criteria were you just had to have a node involved. They didn't look at an additional high risk feature. So here, technically, I would say I think they're a candidate for either abemaciclib or ribociclib. I think the question, though, is what is this patient's risk, right? And Stephen was alluding to that really nicely by really trying to show that these additional features really do guide what we think this patient's baseline risk would be. And here this is kind of mixed because maybe the grade's a little bit lower, but the proliferation is still high. And so I would think they kind of fall in between the two worlds of the ESMO open paper because again, they do have some high risk features. And so I would prefer to give this patient a CDK4/6 inhibitor. And I think either agent in my mind would be appropriate for them.
Yeah, I think you're right. There is still residual risk. I think it's an individual decision, and patients can always weigh in and say whether they want to protect themselves or not. So, I mean, now that the patient was 61 years old, I think we're not concerned about comorbidities too much at that age. But, Stephen, if the patient were 78 years old and take the original patient with the grade 3 tumor, would you still recommend a abemaciclib, or would you maybe be a bit more hesitant?
No, I think the evidence is clear that age is not a barrier to access to these treatments or benefit from these treatments, and that's been shown in the studies. What we find with the older patients, particularly with the addition of comorbidities, is that adverse event rates can be somewhat higher. So I think you just have to manage your patient carefully in terms of dose reductions, adjustments and management of adverse events because there's clear evidence when we've looked at age that they get the same degree of benefit of the drug. It's the adverse event management that has to just be adhered to a little bit more carefully because there was a slightly higher discontinuation rate in the older patients for a variety of reasons. Age does not impair you from getting the treatment. It's just about the management of adverse events and toxicities.
Yeah, I couldn't agree more. And I thank you for pointing out that it's not just the age itself, it's also the number of comorbidities where we have to be a bit more careful. So, Sarah, let's look at the opposite. If the patient were premenopausal, 44-year-old, would you have decided any differently? Would you have any concerns?
No, I wouldn't have decided differently. I still would have recommended CDK4/6. I think here, what we do see is that in our very young patients, their risk is also higher. Their baseline risk is higher. They tend to have biologically higher risk disease. And so we do see a larger absolute benefit in premenopausal patients in some of these analyses, including one that was presented from Natalie. And so, I think it just pushes you a little bit more to make sure that you're really trying to optimize therapy in these high risk patients. And in our young ones, I think we also feel that they often will tolerate therapy. We're often giving them ovarian suppression in an AI. Their endocrine therapy tends to be harder to tolerate. And then we're also adding on CDK. We're often giving them bisphosphonates. We're really trying to optimize outcomes.
Do you have a preference for now this patient with the grade 3 tumor, as we discussed, could have either CDK4/6 inhibitor? Do you have a preference for one over the other? Just because in the monarchy study we had some flexibility regarding the endocrine therapy. Is that a decisive factor for you, or do you think you would always give them an AI, and that's why it's not so important?
Well, I certainly always try to give them an AI since we know that the benefit of ovarian suppression in AI is superior to ovarian suppression in TAM or TAM alone. However, as you point out, this isn't so easy, and there are patients who simply can't tolerate it. And so I am sometimes needing to go to tamoxifen because I want them on something rather than nothing. And there, as you note, we cannot give concurrent tamoxifen and ribociclib. And so if I, for example, started someone on OS plus AI and they were getting ribo, but then they needed to switch their endocrine backbone, then I think that becomes tricky because then you cannot do that with ribociclib. There is concern about prolongation of QTC, more so with the combination of TAM ribo. And so there you'd have to think about switching, to using abemaciclib. And so you're right that the abemaciclib from the get go would give you the flexibility to be able to switch your endocrine therapy if needed.
Stephen, I would just like to pick your brain a little bit about the biology. You've worked a lot also with the KR67, and I was always surprised to see that in Monarch E, with this high risk clinical population, we still see that proliferation matters as a prognostic factor. Let's go back to the 61-year-old woman had a KI67 of just 10%. Would that change your opinion?
Yeah, I mean, that's a very good question. And thinking about really what their risk of recurrence is and what their absolute benefit of treatment should be, which is why in the monarchy, we've probably got the largest data set of the role of Ki67 as a prognostic factor, just looking at the endocrine therapy alone arm. So if you just look at, those 5,000 patients and 2,500 were on endocrine therapy alone, high Ki67 versus low Ki67 was a strong prognostic factor. So, but the benefit of abemaciclib was seen in both arms. So, even in the lower proliferating tumors, and the event rates are slower, the absolute benefit or the relative benefit, sorry, in terms of risk reduction from the abemaciclib is numerically the same. So it's just the events occur much more slowly. So these CDK inhibitors work regardless of whether you've got a more luminal A type cancer or a more luminal B cancer. And in the translational research we've done in monarchy, we've gone on and done, PAM50 luminal subtyping and shown very clearly again, whether it's luminal A or luminal B, absolute risk reduction is very similar. So Ki67 is not a factor to select for CDK inhibitors. It's just a factor that tells you about what your level of risk is, not your benefit from the treatments. And that's been very clearly demonstrated in monarchy now.
Yeah, thank you. I think that's a very important point to keep in mind, Sarah. I assume that efficacy is the most important thing for you, but do you have any advice for us also how to manage these drugs in this early breast cancer setting?
Yeah, I think it's true that we really have to be thoughtful about our approach in terms of trying to make sure that patients are tolerating these agents. They are on them for quite a while, right? It's 2 to 3 years of therapy, and we want to ensure that we're preserving their quality of life with treatment. And so when deciding between the 2 drugs, I think I am thinking about what the toxicity profiles of each drug are and what some of the issues are. So, like, for example, with ribociclib, you pointed out you can't give it with tamoxifen. So if you're trying to use tamoxifen, that wouldn't be a good choice. There is QTC prolongation. So if someone's on drugs that are prolonging QTC, that may be challenging if you can't switch out those medications. And there can be some drug-drug interactions with ribociclib that you have to look out for. Also, if they have elevated baseline LFTs and, maybe they have underlying fatty liver disease or something that may be a little bit challenging with the LFT elevation. So those are things I kind of keep in mind. With abemaciclib, obviously there is a GI toxicity. And so if someone has underlying GI issues, inflammatory bowel disease, things like that, maybe abemaciclib is not the ideal choice in that patient. I also think it's important when they are on treatment that you are really good about dose modifying if needed. So, particularly with abemaciclib, I find going from that 150 twice a day to 100 to make a huge difference in terms of tolerability. And so, if they are, for example, having persistent grade 2 diarrhea, I am not hesitant to hold drug, wait till it resolves, and get them onto that lower dose. There was an interesting study my colleague Erica Mayer had actually done where she actually looked at the reverse. She said, could we actually start at a low dose and escalate them? And would we find that we have patients tolerating this better, meaning we get less diarrhea, less discontinuation? So she did an escalation where she gave 2 weeks of 50 milligrams twice a day, then went up to 100 twice a day for 2 weeks, and then got to the full dose at 150. And, she did find that patients were more likely to be able to hit full dose. They did have fewer discontinuations, and rates of GI toxicity were a bit lower than what had been seen in monarchy when they traditionally started at the 150 dose. And so I think it can be a strategy people could consider. It's nice to have that as a potential option and strategy.
Thank you. Thank you also for pointing that out that we have the option of dose reduction if you want to escalate the beginning. I think that's personal preference, but the dose reductions are so important to keep patients on these drugs. So that was a great discussion. I think we could go on about these practicalities, how we treat our patients. But I think what we've learned from this discussion with Dr. Johnston and Dr. Trelawney is that we definitely know now that adjuvant CDK4/6 inhibitors help to increase the chances for cure in our high risk hormone receptor positive, HER2 negative early breast cancer patients. We do have 2 drugs available. Um, Abemaciclib based on the monarchy study and ribociclib based on the Natalie study. We now have the first time an overall survival benefit demonstrated with monarchy. We waiting for the Natalie follow-up to mature, and those are a bit low risk population, so we may need some longer follow-up to see overall survival data. There's a clear indication, I think this came out during the case discussion for these drugs. According to the study inclusion criteria, monarchy was mostly high clinical pathological risk, and Natalie extends that indication to the high risk node negative um, patients as well. And what we saw with the real world evidence from the Flatiron database, as well as here from our German ADAPT database, is that we actually have this residual risk if we look at these study inclusion criteria. And to turn this around, also patients who do not have the inclusion criteria for either of the trial have a much low risk of recurrence, and we should be comfortable with not giving them a CDK4/6 inhibitor. That also goes into the discussion: do we really need to know sentinel node in those low risk postmenopausal patients? The selection for CDK4/6 inhibitor and the overlapping population, I think Dr. Johnson just summarized that very nicely. We have a different treatment duration. We have the flexibility of the endocrine backbone with the abemaciclib and not with ribociclib. And there's expected side effects that we have to talk to our patients about if we have the choice for an individual patients for either drug. And lastly, I think Dr. Tolani pointed out at the end that the patient adherence is of utmost importance. We have to have proactive side effect management, mostly in the beginning. And then once we sort out the dose, and we should make use of these um, dose reductions in order to keep patients on these drugs. And there is this nice evidence from the trade study that you can do with abemaciclib a dose escalation in the beginning. And with that, I just would like to thank you, both of you, Stephen, Sarah, for a great
Thank you.
discussion. It's always enlightening to talk to you. And
Thank you
I
very
would like
much.
Yeah, thank you very much.
and I would like to thank our audience for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation. Thank you so much.